Okay, so let me just, so evidence-based medicine as a paradigm more than just a term. Remember that आज से कोई about maybe 4 or 5 years ago, BMJ ने एक बहुत बड़ा पोल किया था और उसमें ये फिगर आउट करने के लिए कि कौन सी ऐसी चीज है जो पिछले 50 साल में या 100 साल में जिसने मेडिसिन को सबसे ज्यादा इम्पैक्ट किया है. तो you will be surprised कि evidence-based medicine was at number 7 out of a lot of other things that जो कि उस पोल का हिस्सा थी. तो it as a paradigm it has a lot of meaning, and as we go on we try to explore that meaning and see if we can use that in our practice. Now there are certain questions that we will try to answer today, and ये questions आपके सामने हैं. We will try to explore what is who is an expert, what is reflective practice, how do we make clinical decisions, what is evidence, how evidence is created, what is eventually evidence-based medicine, why do we need to practice evidence-based medicine, and how can we learn practicing evidence-based medicine. These simple से questions are बहुत detailed answers नहीं है. I just will throw in some ideas which probably we can build later on. अगर ये series हमारी आगे चलती है तो इंशाल्लाह we will build on those questions. So who is a medical expert? आप में से बहुत से लोग जो कि सोचते होंगे कि कोई ना कोई definition आपके अंदर होगी medical expert की. And interestingly, this was formally explored lot about maybe 15 years ago in Canada, and they were the ones who went to people. They wanted to know what people think who is a good medical doctor, and subsequently this thing came out of that particular research. And turns out that people opted for certain things in a medical doctor, and those certain things were categorized into broad themes, and those themes were named as CAN-MEDs. Those are called CAN-MED competencies. And subsequently, those competencies were adopted by so many other countries. US developed their own competency framework, जिसको वो ACGME framework कहते हैं. Scotland ने develop किया. Then UK Tomorrow's Doctor के नाम से एक डॉक्यूमेंट पूरा क्रिएट किया. ऑस्ट्रेलिया, न्यूजीलैंड ने अपने क्रिएट किए. And interestingly, even Pakistan had developed a document by Pakistan Medical and Dental Council several years ago, and we, as part of our previous College of Medicine, participated in making that document. So let me show you what is the gist of all that effort. And this one is especially coming from Canada. And Canada has been somehow on the forefront on these kind of things. So this is what they think should be a medical expert. Someone who is professional, scholar, collaborator, communicator, health advocate, manager. So ये वो ingredients हैं जो कि किसी एक डॉक्टर के अंदर हों तो हम उसको शायद मेडिकल एक्सपर्ट कह सकते हैं. Now one can question कि हो सकता है कि कुछ ingredients ज्यादा हों, कुछ कम हों, लेकिन उनके बगैर इन पर्टिकुलर ingredients के बगैर शायद किसी को मेडिकल एक्सपर्ट कहना मुमकिन नहीं है. और इस particular framework को was adopted by a lot of medical schools. They have used it in their undergrad education. Subsequently, they have started using it in their postgrad education, and eventually they are applying it to our real life practice that we are doing on day-to-day basis. So these are so important. So I just want you to know that by definition, it is no more someone who has spent maybe 50 years in practicing medicine, surgery, or any other specialty, but who has these ingredients. And each ingredient, each particular competency has a whole list of things that should be labeled under the heading of a particular competency. So let's move on to reflective practice. I wish कि अगर आप लोगों ने अपने आप को अनम्यूट किया होता तो हम थोड़ा सा इंटरेक्ट कर लेते, लेकिन शायद जूम पे इंटरेक्ट करना सब लोग शायद नहीं इतना आसान समझते. लेकिन reflective practice के बारे में जानना बहुत, and reflective practice is not limited to practice of medicine. It is applicable to all professions. So when it comes to reflective practice in medicine, you would think that, okay, so whatever I am practicing, I should be able to focus, analyze, self-assess myself about that practice. Now, that is an individual reflective practice. It can go on towards a group of people providing care, for example, a team providing care in ICU, team providing care in ops and gynae, team providing care in any other specialty. It can go further and involve transdisciplinary approach where different disciplines sit down and discuss about their practices. And it can even go more proximal and involve the whole institution. That an institution should be able to self-reflect that where do we stand and where do we want to go and how do we want to go to that particular point in time. So if I just put all these things in small bullets, so that you will see that basically it is all about self-assessment or group assessment. It should be able to identify.
1300 बताई थी
जी. क्वेश्चंस हैं कोई? ओके, आइडेंटिफिकेशन ऑफ गैप्स, लर्निंग स्ट्रेटजीज कैसे हम यूज करेंगे उन गैप्स को फुलफिल करने. मैंने एक मरीज देखा, I went through an experience of seeing a patient. I figured out that during that experience interaction, I was able to identify certain gaps, and then gaps could be in learning, gaps could be in communication, gaps could be in ethical or any other dimension. And then I figure out that maybe I need to build on them and learn new ways. And once I have learned the new ways, and the next experience with any other patient or the similar kind of patients is going to be better or different. This is what we call reflective practice. So now we have kind of figured out who can be a medical expert based on people's view, and of course incorporated within the professional domain or professional expectations. And then what is reflective practice as an individual, as a group, and maybe as an institution. So let's move on to build further on another concept, which is how do we make clinical decisions. If you if you sit back, relax and reflect कि मैंने पिछले मरीज जो देखे या मैंने कुछ और पॉलिसी डिसीजंस जब लेने की कोशिश की तो मैंने कैसे लेने की कोशिश की. तो you can probably throw in an idea or your thoughts about it if you have that. How do you make clinical decisions? Anyone who would like to say something? Okay, शायद once again मुझे नहीं पता कि आप लोग कितने सुन रहे हैं, लेकिन coming back, we make clinical decisions through different ways. अगर आप सोचिए जब हम early days में ट्रेन हो रहे होते हैं तो हम हमेशा भागते हैं अपने आसपास सीनियर्स की तरफ. सीनियर्स जो हैं वो अपने सीनियर्स के साथ डिस्कस कर रहे होते हैं, अपने नॉलेज को एक्सप्लोर कर रहे होते हैं, और जो बहुत सीनियर होते हैं वो कहते हैं कि ये है whatever, this is the way things should be done, and then we start following those things. So there are different. तो इन्हीं को अगर मैं नाम देना शुरू करूं तो आप कहते हैं कि हमारे डिसीजन मेकिंग एक्सपीरियंस बेस्ड हो सकती है, हमारी डिसीजन मेकिंग नॉलेज बेस्ड हो सकती है, हमारी डिसीजन मेकिंग कोलैबोरेटिव हो सकती है, कंसल्टेशंस के जरिए हो सकती है, और हमारी डिसीजन मेकिंग शायद एक और तरीके से भी हो सकती है जो हम शायद आखिर में डिस्कस करेंगे, और वो शायद आज ही का टॉपिक भी है, दैट इज एविडेंस बेस्ड. So if I put all these things here, that experiences, prior experiences, more experiences, they all gel in our brain in certain kind of heuristics or shortcuts in very simple ways, and we figure out, okay, this is the diagnosis, okay, this is what I have to do, this is run-of-the-mill asthma case or appendicitis case or any other specialty that you belong has a particular bread and butter case. So this is the way generally we are doing our decision making. And we start discussing in teams, discussion, support. This kind of decision making generally is going to be a little bit more complex because more specialties will be involved, and generally the cases are going to be a little bit more complex. Patient-centered decision making, and remember that whatever we decide in terms of care has to be discussed with the patient, and then maybe your patient may not like what you have made or what you have decided for the patient. So you have to come to some kind of trade-off, which will leave you with what we call shared decision-making model, where you incorporate patients' wishes. Evidence-based, and we talk about somewhere down the line, not in this particular talk, that probability-based decision making, where you make probabilities. अगर आपको बेसन थ्योरम का कुछ आइडिया है कि हम जब मरीज देख रहे होते हैं तो हमारे जहन में probabilities चल रही होती हैं prior knowledge या prior evidence के हवाले से, वो probabilities modify होती रहती हैं history के हवाले से, फिर उसके बाद अगर हिस्ट्री से हमें बात नहीं बनती और हमारी प्रोबेबिलिटी इतनी हाई रेंज में नहीं पहुंचती जहां पे हम एक डायग्नोसिस को एक्सेप्ट या रिफ्यूट कर सकें या एक थेराप्यूटिक डिसीजन को फाइनली एक्सेप्ट या रिफ्यूट कर सकें, तो हम और टेस्ट कराते हैं, वो टेस्ट हमारी मदद करते हैं. तो दिस इज व्हाट वी कॉल प्रोबेबिलिटी बेस्ड डिसीजन मेकिंग, जो कि very much is the norm these days. And even if we explore our own brain models, most of us are doing this, except that when you incorporate it with patients' values and decision making and shared decision making, eventually, then it becomes more of an evidence-based approach. So now you know that there is a medical expert who needs to have certain ingredients, and you also know that there is some kind of an evidence, research evidence we are talking about. And then you also know that you have a patient who has his or her own values and preferences. So in सब का इम्तिजाज eventually हमें एक नया paradigm देने की कोशिश करेगा. And so before we go that, let's figure out कि हम evidence किसे evidence कहते हैं medicine में. Evidence has to be so-called research evidence, and systematic research has to go through certain steps based in वो steps जो हैं वो conceptualization से practical जो हमारा implement करते हैं अपनी protocol से, analysis से, synthesis और conclusion से, सबसे वो निकल रहे होते हैं. तो आप देखते हैं कि जब भी आपने कुछ करना होता है तो आपके जहन में बहुत सारी चीजें आती हैं, and this is the way you kind of create evidence, and then that evidence once published is archived, and then once archived can be retrieved by various people anywhere in the world, and then you start using that evidence in care of your patients. हाँ, इसमें bias free approach का खास एक focus है, appropriate study designs का एक focus है, जो थोड़ा सा अगर आप इसको इन बातों को अपने ज़हन में रखें तो down the line we'll discuss these things. Peer reviewed होने का भी एक important perspective है जो कि थोड़ी देर में आपके सामने आएगा. So the question is कि how evidence is created. ये भी एक interesting सा cycle है कि आप भी जानते हैं कि you start having ideas in your brain, you discuss with people, you see patients, figure out that there are gaps in research, and you go back to your prior knowledge or prior corpus of research and figure out कि आपका जो idea है वो उस particular topic में कहाँ fit in होता है, कहाँ किस gap को identify करता है. आप अपना कोई सवाल लिखना शुरू करते हैं, फिर research का कोई design बनाते हैं, फिर आप कहते हो कि यार एक unbiased तरीके से मैं data gather करूँगा और बड़ा एक तगड़ा सा analysis करूँगा जिसमें कि जितनी भी बेहतर तरीके से हम data को analyze कर सकेंगे, वहाँ से conclusions कुछ निकालूँगा, और eventually उन conclusions को जो कि valid होंगे after going through these steps, advertise करूँगा, disseminate करूँगा, publish करूँगा ताकि वो conclusions जो हैं वो use हो सकें. Now this is a kind of a clinical research way of doing things, and something similar also happens in preclinical research. तो अब अगर ये सारी चीजें हम देखना शुरू करें तो you will see कि कुछ ये तीन बड़े broad areas develop हो रहे हैं. One is what we call relevant scientific evidence, relevant, pertinent to that particular patient, the one that is sitting in front of you or lying in the bed in front of you. And then you have your own judgment, being a physician, medical expert who knows how to use evidence. And then you have your patient who has his or her own values and preferences. अब जब ये तीनों चीजें आपस में कहीं मिलती हैं, तो जो पैराडाइम प्रोड्यूस होता है, and that's what we call evidence-based medicine. The question is कि ये तो मैंने कह दिया और बना दिया, और question is कि ये formally कहाँ से आ रहा था, किसने काम किया था. इसके पीछे जो छोटी सी स्टोरी है वो मे बी कुछ का ताल्लुक शायद इसलिए कि मैं उस एरा में रहा हूँ, तो I can probably say a few things. So when I was doing my residency in 90s, mid 90s, तो US में there is no such thing. कभी hardly शायद evidence का नाम तो हम सुनते थे, लेकिन evidence based medicine का नाम बहुत rarely सुना जाता था. लेकिन just across the border north में as usual, McMaster, Canada, जहाँ से चंद लोग इकट्ठे होते हैं, दो बड़े नाम जो कि शायद down the line कहीं न कहीं आपको नजर आएंगे, David Sackett और Gordon Guide. Sackett originally was an American, trained in US, went to McMaster. Guide was one of his kind of a colleague student, and they were the ones who started thinking about, okay, yes, we are practicing, we are using evidence, but all evidence is not equal. That was one of the very important statement that they really popularized, that all evidence is not equal. So once that happened, then they started to work on, okay, how can we create evidence? How can we incorporate patients' wishes? How can we make a doctor a different kind of a doctor or a medical expert? So all these things were eventually they came together to this particular paradigm, and somehow the name was first time published by Gordon Guide, I think in early 90s in JAMA, a series of articles जिसमें के Gordon Guide ने evidence-based medicine के principles की बात करना शुरू करी. So ये वो लोग हैं. On your left is Gordon Guide, on your right is David Sackett. I happened to meet Guide first time, I think in 2002 or 3, शायद somewhere in Saudi Arabia. And he was later on, he came twice at Shifa, where he conducted workshops. On the right is Sackett. Sackett, जो कि US से Canada और Canada से Oxford. अगर आप लोग जो UK से हैं वो जानते होंगे कि Oxford में एक Center for Evidence-Based Medicine है. That center was established by Sackett. And he was in fact invited at that time, and then he moved to UK and stayed there for a long time, and then he went back to Canada. और गाइड जो है वो इन दोनों ने एक जो eventually जो define किया evidence based medicine वो ये था कि evidence based medicine is the conscientious, explicit, judicious use of current best evidence in making decisions about the care of individual patients. अगर आप देखें तो यही तीन चीजें इसमें मेंशन की गई हैं, patient or evidence or physician. So it is the right use of current best evidence. Who is going to be doing it? Physician, in making decisions about the care of individual patients. And later on the concept expanded to evidence-based nursing, evidence-based other specialties, evidence-based policy making, evidence-based public health. You name it, and everything has attached evidence-based with it. So question is why practice evidence-based medicine? हमें change होने की जरूरत ही क्या थी? हम तो बेहतरीन काम already कर रहे थे, तो फिर क्या हुआ? फिर ये हुआ कि you all know कि जो एक explosion है research के हवाले से, IT के हवाले से, engineering के हवाले से, physics के हवाले से, वो सारा explosion चूँकि एक integrated तरीके से ही हो रहा होता है, हर specialty या हर profession जो है उससे affect हो रहा होता है, तो medicine भी उससे affect हो रहा था। शायद मैंने इसमें एक slide नहीं डाली, जिसमें you will be surprised कि 1990s में जब मेडलाइन एक ज़माने में सिल्वर प्लेटर पे आया करती थी सीडीज के ऊपर, तो हम लोग वो एक बड़ा सा बॉक्स होता था, टावर होता था, उसमें कोई 50-100 सीडीज लगी होती थी और हम उसमें सर्च किया करते थे। लेकिन उसके बाद वो वाज नॉट इनफ, इवन डीवीडीज वर नॉट इनफ, तो तभी फिर वो इवेंचुअली वेंट बैक टू पबमेड बना, जो पहले मेडलार्स था और फिर मेडलाइन, और फिर यानी वो सारा एक पूरा जो कॉन्सेप्ट था वो इतना एक्सपैंड कर गया। उसके साथ साथ जो बाकी चीज़ों में बहुत ज़्यादा चीज़ें नहीं आ रही थी, उन्होंने सबने मिलकर फिर पबमेड की बुनियाद रखी। इसी तरह नर्सिंग वालों ने सिनाहल के नाम से एक और उनका डेटाबेस क्रिएट किया। तो इतना कुछ, इतना ज़्यादा एविडेंस आ चुका था, इतना ज़्यादा एविडेंस आ रहा था जिस तेज़ी से, यू विल बी सरप्राइज्ड कि सैकेट जो कि 20 साल से मेडिसिन प्रैक्टिस कर रहा था और प्रोफेसर था एट मैकमास्टर, he went back and did his residency again. Can you imagine? Only he could do it. I won't be able to even think of doing that again, but he did it. And he trained himself again because he thought that whatever he learned 20 years ago may have some meaning, but the new evidence has changed so many things. So that's the bottom line, the crux, that we have to keep ourselves up to date. And this is what we call lifelong learning and stuff. So that's why we need to practice evidence-based medicine for the care of our patients, commitment to our profession. We know that healthcare outcomes are constantly being monitored, and a lot of therapies are being produced which are going to impact the outcomes. Commitment to lifelong learning, it is a personal goal for a medical expert, the true medical expert. And of course, patient-centered care. Now, this is an interesting study. Again, was done at McMaster, published in Canadian Medical Association Journal long time ago, and it simply tells that we are sitting at the top of this slippery slope. And this was just done basically on the knowledge of hypertension for people who have graduated, and those who were graduated 20 years from from time of graduation had probably the least up-to-date knowledge as compared to the fresh graduates. So if we are not cognizant of the fact that our knowledge is going to be obsolete pretty soon, then we are kind of slipping down the slope very easily. So in order to be on the top of the slope, one has to be extremely active and up-to-date in terms of recent knowledge, not only knowledge, but also the skills to analyze the right kind of evidence. So again, we all know that traditional textbooks are probably out of date. The editions are coming after 3-4 days. That concept mostly has been modified in the last several years, where textbooks have gone online. Our traditional experts, not the experts that I described initially, who has all those ingredients, their decision making was something in a different way, and we might probably can remember some of our professors in those days. And then there is so much evidence available that it is very hard for everyone to figure out which one to use and which one not to use. In other words, if you go to Medline or if you go to Sinal, the nursing evidence, you'll be surprised that there is so much research. And something similar we also did. I think you are probably seeing a couple of small publications that some of my students did some time ago. And it also found a similar kind of thing, that our knowledge about latest guidelines was extremely poor when it came to physicians who are in practice. Okay. So this is another thing that one need to know, that creating an evidence is one thing, and utilizing an evidence or active use of that evidence is another thing. So there is always a gap between evidence and practice. And that gap needs to be filled with very active self-reflection or institutional policies or national policies in terms of the re-accreditation for physicians, that is at least in practice in US and UK and maybe some other Western countries, but not really in the Eastern side. So that gap needs to be bridged, and that can only be bridged if there are policies, if there are individual skills at play, making sure that we are learning what is required and we are making sure utilizing the evidence which is already there but not being utilized. I think one of the recent example is COVID. And as you all have gone through that pandemic, and we are still going through that pandemic, the questions are changing. We started from hydroxychloroquine, azithromycin. We started using, antivirals, whatever was available. That was all kind of panic response. And then when panic kind of settled and people who were asking questions critically started to do research, and then we figured out then, okay, recovery trial comes in, then, a trial about remdesivir comes in, and the controversies start, and then some guidelines started to filter in, and then baricitinib and other monoclonal antibodies, their role. So if you see yourself now, then we are still we are using a lot of things that have no evidence, unfortunately, but yet we keep using them because our own values and preferences sometimes just take over the scientific evidence, and that's what is happening because of overuse of antibiotics. Sometimes a lot of other therapies which have no basis, but yet we are prescribing them with such an intense recommendation that patients, and a lot of patients are doing things on their own. So that practice, that gap between evidence and practice is always going to be there and can only be blocked or bridged once we are cognizant of the valid evidence. Why do we need evidence-based medicine in developing world? We have limited healthcare resources. Our paying capacity is a problem. Our diagnostic workup is extremely expensive, not affordable for most of the population. Drug regulation is such an issue here. Just we can get medications smuggled from just across the border. Our opportunities for CME, though probably in larger cities is not an issue, maybe, but surprisingly, even any, if you start going to cities other than major cities, there are a lot of issues. People are not even aware of the resources which are available and can be utilized, especially those who have graduated maybe 15, 20 years ago. More vulnerable population, we know that our population leaves decision-making in our hands. And at times, if we are not playing as their best agents, there is a for exploitation. Doctors are also vulnerable. We all know that, we have a lot of interaction with industry, and our vulnerability gets exposed pretty easily. This was a small study done at AKU 2008, in which they looked at the various advertising by various companies to project their products. And if you look at it, that they checked about 559 references, and out of them, 44% were not even traceable. And if you go at looking at the data, and you'll be surprised that the kind of information provided to us by these medical representatives is so ambiguous, and very rarely they cite the right kind of literature to support their product. So that is why it is so important for the physician to be up to date, so that they can deal with these representatives presenting information. Okay, so it was supposed to be a small exercise for you all. This is what we call evidence pyramid, and I'm sure that you all know that the weakest evidence is at the bottom and the strongest evidence is at the top. And when I say strongest, that means the one which has the highest validity, and the one which has the lowest validity is supposed to be at the bottom. Now this evidence pyramid is different based on the type of question that we are dealing with. For example, if a question is about a therapy, then this pyramid works very well. If the question is about prognosis, if a question is about a diagnosis or harm or etiology, then the pyramid has to be arranged a little bit in a different manner. But just to be on the easier way of looking at things, let me see if okay. So background information and expert opinion is supposed to be something at the bottom, and I guess you know why is that. When we start doing systematic research, the case control studies, case series, reports, they are still at the bottom, but better than, of course, expert opinion. Cohort is a little bit better designed. When I say cohort, that is an epidemiological cohort. I'm not talking about an experimental design. Randomized control trials are, of course, excellent when we talk about therapy or intervention, any kind of intervention. Of course, once we have several randomized control trials available, or several cohort studies available, or several case control studies available on a particular topic, we can synthesize that evidence and start creating synopses. And those critically appraised topics can go into synthesis, evidence-based guidelines, and we talk about some of the resources which are targeting these particular higher level of synthesized research. And of course, systematic reviews. We all know that systematic reviews are basically just piling up of similar kind of studies to broaden or increase the sample size, to increase the validity of conclusions. And these systematic reviews can be of RCTs if the question is of therapy, can be cohort studies if the questions are about harm or any other interventions which cannot be studied through randomized controlled trials. And then these systematic reviews can also be of case control studies in situations where cohort and randomized controlled trials are not feasible. So systematic review can be of any such design as long as the question that we are trying to answer is appropriately answered. So the bottom is like more of what we call unfiltered information, and on the top of the pyramid is filtered, and we'll discuss in a second what does that mean. So how can we learn practicing evidence-based medicine? This is a small framework. You can have your own. I'm sure most of us probably do the same. We interact with patients, we interact with colleagues, we go to conferences. We are in the morning reports, we are sitting and discussing our patients, and questions arise. Yesterday, we were discussing about vaccinations, and questions arise about their safety, their efficacy in different ethnic groups, and then vaccine nationalism, the term which is coming up. Dr. Bakar shared an article yesterday. So we were asking questions, and in order to answer questions, you need to acquire evidence. And acquire evidence means that you need to have skills to access evidence. And you know that we'll figure out that how to access unfiltered evidence and what is the best way of accessing synthesized or filtered evidence. Appraisal is required, and we will talk about critical appraisal skills. I think the last journal club was an effort from Office of Academics just to broaden our understanding of critical appraisal, especially of randomized controlled trials. We have tried analyzing cohort studies as well, but once you know those things which are important ingredients for the internal validity, only then you can start using that information or evidence as your valid evidence for patients. Of course, applying is another art. You might have a wonderful evidence available, you might not be able to apply for various reasons. Apply means using that evidence with your patients. Your patient may not accept it. Your patient may not be able to afford it. Your patient may be so different from the study population that it may not be feasible for that evidence to be applicable. So many things come into play. And of course, you start to analyze the process as well, that you have gone through an experience. So how does that experience change your future practice of medicine? So this is what we call self-reflection. So asking a question is most important while dealing with patients, and question can be raised by a physician, nurse, or pharmacist, or a respiratory therapist. It's all medicine. We are all just part of the same team. And questions can be of diagnosis, therapy, prognosis, harm, ethical, prevention. Questions can be asked by patients or families. A lot of people who come to our office asking questions about use of certain medicines in certain disease, and they have questions. They have gone through some of the information available on the internet, and then they want to discuss about it. And of course, discussion in morning reports, discussion bedside, discussion in rounds, discussion with colleagues. They can also, so raising a question is so important. Asking a question, and there are so many questions that you may ask. That's just an example of questions. And the last one is vaccination effective in preventing COVID, and especially in different ethnic groups or different populations? So these are some of the questions. Now, the purpose of this particular slide was just to give an idea that a question can be broken down into what we call Pico Framework, where P is the patient, I is the intervention, C is the comparison of the intervention, and O is the outcome that you're looking for. So Pico Framework can be used for a diagnostic, therapeutic, etiology, or harm related question. The advantage is, by doing that, you will find the right terms to search your question, be it unfiltered or filtered resources. So this is just an example that you can see. We are doing it, but doing it in a more precise manner is more helpful. Acquiring evidence, we all know that when we talk about PubMed or CINAHL, these are the unfiltered evidence, meaning thereby the original research, including systematic reviews, including review articles are there. And then of course, there are very filtered resources. For example, Cochrane is all about systematic reviews. UpToDate is a system. It incorporates various topics appraised in a very evidence-based manner. Medscape is another one. BMJ Evidence is another one. So they are what we call filtered resources, and especially for those who may not have enough appraisal skills to go through systematic review, quality of systematic reviews, or quality of randomized controlled trials, cohort, or other designs. So primary evidence and secondary evidence. So critical appraisal, if you want to go through, as we go through in our general clubs, the purpose is to evaluate for internal validity. For example, how the question was generated, were the methodology adopted was appropriate, and were the analysis and all those things were done in a very unbiased fashion, and the conclusions were appropriate. And then there are steps, as you might hear that we keep talking about relative risk or ratios, confidence intervals. We talk about intention to treat analysis in randomized controlled trials. We talk about randomization. We talk about blinding and its types. The whole purpose is to make sure that a particular study is internally valid. We talk about designs, be it cohort or case control or randomized or quasi-experimental. So all these things are related to internal validity, and they all are addressing bias, minimizing. We are focusing to minimize bias, and we are making sure that we have enough precision of results to be applicable to our patients. And of course, external validity is all about using the evidence in real life, and that is the real challenge. So we know that appraisal skills are not easy for everyone to develop, so it needs active learning. And can we utilize evidence without having enough appraisal skills? Simple answer is yes, and I think you know why it is yes, because there are resources which are basically using synthesized research. So for example, as I mentioned, that systematic reviews and meta-analysis, these are syntheses. There are journals, for example, people who are aware of ACP Journal Club, Evidence-Based Medicine, EBM Journal Club, they are the ones who are actually analyzing articles. And there are up-to-date, which is basically summaries of appraised topics and evidence-based guidelines. And those of you who are practicing with EPIC probably will know that computerized EMRs they have gone to that extent that they will even start giving you feedback on your various decisions that you are taking. So that is a very interesting thing, which at least I am learning in the last maybe year and a half or so. And I'm sure some of the others who are practicing in US know that EPIC is one of the EMRs where these days, even the residents working in US, their decision making is analyzed through those decisions that they make, and they are provided feedback in terms of their weaknesses and the areas of their strength. So these are the filters. These are the what we call a 5S grouping done by Brian Haynes, once again from the same McMaster group of Guyot and Sackett. This is again the same thing mentioned in a little bit more different manner and incorporating all the things that I was saying. So here is the your studies. This is what we call your primary evidence. And then, of course, difference between primary and secondary, and the examples from each category is available. So applying evidence is, as I said, is a very difficult thing. You know, yes, there is an evidence. Yes, there is an efficacy. Yes, the evidence, the therapy has potential for modifying important outcomes, but yet patients may refuse it. Patient may not be able to afford it. So it is so important that we address all these things: patient-related factors, you know, biologic access issues. Access to healthcare. Our values are different. You know, as a pulmonologist, you know, so many times we have to grapple with use of inhalers in common people. People tend to refuse because somehow the societal value is that using an inhaler has issues, you know, related with it, and the values are so strong that it's very difficult, not an easy job to do what we call cognitive behavioral therapy to fix that issue. Physician-related issues, we know that you know, sometimes we project our values to the patients to the extent that we truly become or start practicing paternalistic approach in dealing with patients. So that becomes an issue as well. So so that's why we need all that reflection. I did mention reflection on action, in action, and for action. Those are just ways of expressing your thinking processes. It is always good to be reflective while you are doing things or while you are planning things. A reflection afterwards is also of great benefit, but those two reflections, what we call inaction and on action, are truly helpful. So broad themes out of today's discussion seems like that there is a gap between evidence and practice. Shared decision making on individual values need to be incorporated as part of evidence-based paradigm. We kind of scratched a little bit about reflective practice. Lifelong learning is an individual's goal, important to tool ourselves, be it we are undergrads, be postgrads, or even practicing independently. And we need practicing role models. If we really want to have this kind of approach in decision making, we need to have role models, especially for those who are still in the learning phase, for our PGs, for our undergrads, so that the system keeps moving in a particular direction. So these are interesting books. Maybe you want to have them. I have probably all of them. If you like, I can give you copies. You can make photocopies. I may have PDFs. Most of them are from Sackett or Gordon Guide, and they are wonderful resources. I think they are probably available easily over the you start exploring through various, PDFs or whatever, but they are wonderful. And I think this one, probably testing treatments, was really interesting, because I think it gives you a very different perspective in medicine. But the rational clinical examination is by JAMA, and it is available on the net. And this is once again through JAMA. I'm not sure it is available, but I do have a copy from Gordon Guide, and this one is from the same group, but a little bit different perspective. And here I think Haynes was the most dominant editor. So anyway, so this is what it is, and I hope evidence-based practice will leave you with more questions and for you to answer for things that you might have to learn. And I'll stop here and entertain any questions if you have. So if you have any questions, feel free to ask, say, comments.
Assalamu alaikum, Mobeen.
You are
Thank you so much. Very, very nice and nicely put summary of the movement, I would say, of evidence-based practice. I think one of the things that, having been exposed to education, you obviously have in-depth experience there. So I would say that the original pyramid that Gordon Guide put together, I think there needs to be a change in there. And looking at the current role model or the current medical expert that CanMed's competencies also define, perhaps the evidence-informed expert. So the whole definition of that expert needs to be relooked at. Unless somebody is an evidence practicing practitioner, he cannot be an expert. So the expert opinion, which was right at the bottom, I think probably is more like a self-actualization, and now needs to come at the top, where the expert has to be redefined as somebody who incorporates best evidence and incorporates all the tools and competencies to practice as a practitioner. And what do you say about that? Do you think that perhaps that needs to be revisited and redefined?
You're right. I think, remember that all this thing, if you look at the movement, early part of the movement in 90s, so things are a little bit different now. But the only question to me is that have we gone to that level, especially in our part of the world? Even in US, unfortunately, still, once in a while when we interact with people, still some of them are not up to date. The question is, yes, if it goes at the top, then it has to be the medical expert defined as by whatever criteria. Because if those explicit criteria are not mentioned, then people can be easily, they can fall in the trap of the traditional expert, which is such a problem. I think even now it is a problem. But otherwise, if we put it at the top, then it has to be very clearly defined that who is an expert and what is the evidence that this person is an expert of that quality.
Right. Thanks. Because I thought that, because obviously things have to be looked at as an evolutionary process, and evidence-based practice with values and all those things coming in obviously evolved, and that therefore I think the expert also, to be truly called an expert who practices automatically using all the evidence, I think that is the role model one is still seeking. I think that you're right in addressing that. Thank you so much. Thanks.
Any other question? Okay, so if there are no questions, just another quick comment. That evidence pyramid is basically evidence pyramid. When we talk about research evidence. So, for example, if you look at PubMed, where all the primary evidence is archived, so the evidence can be a traditional review, can be a randomized control trial, or a cohort, or any other research design. So when we are kind of categorizing that evidence from that point of view, that particular pyramid holds good even now, except that if you look at the evidence grading as done by Oxford and Center of EBM Toronto, what they have done is that they have separately developed this pyramid for the type of question: diagnosis, therapy, harm, etiology, or any other, or prevention. So those are available in fact, but generally for the sake of simplicity, that's why this particular evidence. But the other question, your point is absolutely valid, that if a truly a true medical expert should be the real practicing model as a paradigm representative. I think in that case, you're right. Thank you so much. If there are no questions, and we'll try to build further on this particular primer by going through some of the details or some of the things that we discuss in our general clubs. Thank you so much.
Thank you.